I would be talking about intraoperative OCT guided DMEK. I know I'm standing between cornea and retina session, cornea people waiting for it to get over, and retina people also waiting for it to get over so that they can start. And I will quickly cover this topic, intraoperative OCT guided DMEK. I would like to thank Professor J.S. Tityal, sir.
Is there any option for common men like us to have the intraop OCT, cheaper options, made in India options?
You can have, I think it all began with the handheld OCT systems, and they also gave a very good result. Only thing you had to stop the surgery and put that device in, and then see what is happening in these cases. But that is a difficult proposition, and the cost may be less, but ultimately I think we need to work out in various Indian manufacturers also to have some sort of OCT attachment in these cases. So that will definitely be helpful.
Sometimes even a simple slit lamp attachment on a microscope can give you so much information, and it used to exist in the older models. Somehow the newer models, because of lack of people purchasing them, they've stopped making them. But if you saw Dr. Kinoshita's video, did you see the slit constantly in the so he's actually able to tell at what depth he's working. So the OCT is of course a fantastic tool, but it's a crore of rupees.
Yeah, absolutely. That was a beautiful picture he showed. But whatever slits we have in our microscopes, they don't give a good slit picture on the table. That's a difficulty. Like we do have a slit in a microscopes in a LASIK and SMILE systems, but hardly you can see through those slits. You're there.
Sir, no, it's not there. Actually, this is the presenter view. It's not. No, this.
Do you have a video separately that you could just play on the video?
No, just wait. Okay.
So are there any Indian companies working on this intraop OCT?
Not yet. I think we have to talk to them. Maybe they can get it. In fact, internationally also there are very few companies working on this. Now we have 3 or 4 companies who have come out with the OCT attachment. And apart from the Zeiss, Lumira we have, then now we have other companies making a smaller window is coming.
Yeah, all of them are coming. Yeah, so thank you, Dr. Tityal sir, for buying how many intraop OCTs now in RP Center so that each one of us can use it. There are no financial or proprietary interests, and it is a useful tool, non-invasive diagnostic technique. Although there are various varieties which are available, but what we use is the third one, that is the microscope integrated optical coherence tomography. And it gives you the real-time images with dynamic visualization. It gives you a continuous and simultaneous acquisition and display of the OCT images while the surgeon looks at the eyepiece and does his surgery. Of course, the flip side is that it is expensive and it may not be available at all centers. So, coming to the donor dissection, I think it really does not matter whether you have it or not, especially when you're doing a DMEK. And DMEK is the most physiological graft that is there because there's no stroma at all, and this is the pure Desmet's roll which is being fashioned after detaching it from all sides and then trephinating it right in the center and then laying it back. So this is essentially made to make an S-shaped stamp on it. And if you don't have the intraop OCT microscope, this is very important because then you won't know which is endothelial side up. So S means stroma. So if the correct side is up, then what you will see will be a correct S staring at you. So this is the Desmet's membrane roll which is taken, on which the S is marked. And this is then placed in the media, which could be any preservative media. Then this is a case of Fuchs dystrophy with cataract, for which the cataract surgery has already been done, and Desmet's membrane, which is diseased, is now being removed with the help of reverse Sinski. And the Desmet's membrane roll is then taken and is injected inside. Now what you have to get is this biceps curl upwards. So now if you see, this is an upside down roll because the biceps is curling downwards, which it should not. And when you inject some fluid, the biceps curl upward configuration is obtained. And then you can inject air bubble, and then you know that the graft is stuck to the back of the cornea. So this is the post-operative picture on week 1. And this is at month 1, and you can't even make out that there is a Descemet membrane graft which is there. Even it is very difficult for your fellow ophthalmologist also to make out that there is a Descemet membrane or a DMEK procedure which has been done. Now in hazy media, it has a very useful role to play because you sometimes cannot see the S-marked stamp, and the desmetorexis is done. There may be remnants which may be there, which again can be seen very nicely on the intraoperative microscope, and the Descemet membrane physiological graft is now injected intracamerally. Now this is a tight scroll, but again notice that once you get this configuration of biceps curl upwards, then you know that your endothelium is down, and then air bubble is instilled again, and the graft gets stuck to the back of the cornea, and you can even see a very faint S which is there. So this is the post-op picture which keeps clearing over a period of time. Now even when there are folds present in the Descemet membrane graft, even those can be addressed on an intraoperative microscope. Now as air bubble is instilled, notice that there is a small fold which is present here. So looking at the intraoperative microscope, one goes and injects fluid between the fold and the overlying stromal layers, and then injected air bubble, so that fold gets unfolded, and again you know that the correct side of the graft is there by the stamp and also by your biceps curl orientation. Now in cases of eye syndrome, it is very useful because you have adhesions of iris which are actually at the back of the cornea, and these can be addressed looking at the intraop OCT microscope. Again, the desmetorexis is done, the Descemet membrane is removed, and then the graft is then injected, and air bubble is then instilled so that the graft gets, there's no gap between the graft and the overlying stromal layers. And this is the picture in the post-op period with the clear graft. Sometimes even when DSEK fails, such as this, you can do a DMEK. So this is a failed DSEK graft which is being removed, failed mainly because of the adhesions which are present between the iris and the DSEK graft there. And this is the Descemet membrane roll. You can in fact load your graft in the manner in which your biceps curl is upwards, as seen on the intraop OCT microscope, and then subsequently the graft is tapped into position and an air bubble is instilled, and again the S is looking very much correctly. This I called auto DMEK because the surgeon actually aspirated the entire Descemet membrane, and it came out, and the surgeon said that I have just put the graft inside, hydrated the wound, and this patient was sent to us. So immediately the patient was taken up in the operation theatre. Again, very difficult otherwise to know which side is up. But if you have that entire piece of the Descemet membrane, and you can make out that it is scrolling with the biceps curl upwards, and then subsequently the air bubble can be injected. So this is the patient's own Descemet membrane, and I call this procedure the auto DMEK after putting air bubble so that the graft gets stuck to the back of the cornea. So to conclude, intraop OCT is a useful tool in the armamentarium of keratoplasty surgeons and cornea surgeons, helps to see third dimension of the corneal layers in vivo, acts like a third eye and enhances the visualization, and refines your DMEK surgeries because it helps to see the unseen. Of course, modifications and quantifications are required in the current system for accuracy. Thank you very much for your kind attention.
Excellent as always, and very exciting to see technology helping surgeons so much. Can I request the Chairman's Corner, Professor Titial, to start with for the vote of thanks and winding up?